Clinical case vignette, radial nerve injury. A 28-year-old male presents to the emergency department after a motorcycle accident in which he sustained a mid-shaft humerus fracture. He complains of weakness in his right hand and difficulty extending his wrist and fingers. On physical examination, wrist drop, inability to extend the wrist, weakness in finger extension, decreased grip strength, numbness over the dorsal aspect of the hand, first web space, intact elbow extension, tricep strength normal. X-ray of the right arm confirms a closed displaced midshaft humerus fracture. Question 1. Which of the following is the most likely site of radial nerve injury in this patient? A. Axilla. B. Midshaft of the humerus. C. Lateral epicondyle of the humerus. D. Proximal forearm. Answer. Rationale. The radial nerve runs along the radial groove of the midshaft of the humerus, making it vulnerable to injury in humeral fractures. Axillary injuries, A, often occur due to crutch use, while lateral epicondyle, C, and proximal forearm, D, injuries affect the posterior interosseous nerve. Question 2. Which of the following physical exam findings is most characteristic of radial nerve palsy? A. Ulnar claw hand. B. Hand of benediction. C. Wrist drop. D. Froment sign. Wrist drop is the hallmark of radial nerve injury because the nerve controls the extensors of the wrist and fingers. Ulnar claw hand A and Froment sign D are seen in ulnar nerve injuries, while the hand of benediction B suggests a median nerve lesion. Question 3. Which muscle function remains intact in a patient with a radial nerve injury at the humeral midshaft? A. Triceps brachii. B. Extensor carpi radialis. C. Extensor digitorum. D. Brachioradialis. Answer. Rationale. The triceps brachii, responsible for elbow extension, receives innervation from the radial nerve proximal to the midshaft of the humerus. Therefore, a midshaft injury typically spares elbow extension but affects wrist and finger extension. Question 4. What is the best initial management for this patient's radial nerve injury? A. Immediate surgical exploration. B. Radial nerve decompression. C. Conservative management with splinting and fracture stabilization. D. Corticosteroid injection. Rationale. Most radial nerve injuries due to humeral fractures resolve spontaneously within a few months. Conservative treatment, splinting, physical therapy, and fracture stabilization is the first-line approach. Surgery A-B is considered only for severe or persistent cases. Would you like any modifications?